I welcome everybody to a talk that I'm going to give. My name is Dr. Ross Hauser, coming to you live from Fort Myers, Florida, at Caring Medical, Florida. And I just want to thank Izzy, who's here, and Nicole. They put a lot of work into the PowerPoint and getting this set up today, so thank you guys. I definitely need a live audience, so I really appreciate all of you listening right now. And then, of course, I want to take questions. So if you have any topic on osteoarthritis and prolotherapy that you want covered today, please, what is it? They type in, type live any questions you have, and then my staff here will ask me the questions throughout the talk. Osteoarthritis, it's the #1 disabling, painful condition in the world. Today we're going to talk about eliminating chronic pain from osteoarthritis and restoring function with H3 prolotherapy. As you know, we have a clinic here in Fort Myers, Florida. I've been doing personally prolotherapy for osteoarthritis for about 27 years. Dr. Woznicka and Danielle Stylen Matthias, they're pictured there in front of the Florida office. Anyone who has any questions about your condition, or you want us to evaluate your condition, or any questions regarding this talk, please email me at drhauser@caringmedical.com. Also, I've written several books on prolotherapy. The book that I recommend that people read is Prolo Your Pain Away, Curing Chronic Pain with Prolotherapy. If you want a free copy of that book, please go to our website or email me that you want to get a download of that book. We'll do it for free. There's an amazing chapter on osteoarthritis in the book, so please email me at drhauser@caringmedical.com. Our goal at Caring Medical is always to cure pain and not manage it. The first thing to learn from the talk, and I really recommend that if I say something and it seems that it's important, so hopefully I'll say a thing or two that's important, please write it down, because if you write something down, you have a lot more chance of keeping it in your long-term memory. So there are going to be times during the talk where I'll repeat something like several times because it's a main point. And one of the main points, which I'd love you to write down right now, is arthritis pain is from the ligaments. Arthritis pain is from the ligaments. So when somebody has pain and they have like an arthritic knee, the actual pain is coming from the ligaments, the damage to the ligaments. And it's damage to the ligaments that causes the joint to be destroyed. What? Okay. So I'm speaking pretty loud though. Since 1993, Caring Medical has been one of the world-leading clinics in regenerative medicine. As you know, we treat people from all over the world. So we saw a patient yesterday from Europe, so it's very common for them to come from all over. Together with my wife Marion, who's here, she's our CEO. We started Caring Medical in the early 90s, and we've written a total of 9 books on natural health, but most of those books on prolotherapy and how prolotherapy can help arthritis pain, headache pain, fibromyalgia, knee pain. So there's actually a whole book on Prolo Your Knee Pain Away. And that book also has a lot of information on prolotherapy for the treatment of osteoarthritis. Another very interesting book is Prolo Your Sports Injuries Away, for those people who have sports injury that's not healing. So that book covers all the different kinds of athletic injuries. Next. Now, as we said, the degenerative process starts with ligament injury. That's what this figure is showing. It's showing an injury to one of the ligaments. Then when you get a ligament injury, eventually that side of the joint starts degenerating. And the word degeneration actually means cell and tissue death. So whenever you hear like somebody has degenerative disc disease, that means that there's actually disc cells dying. If you have meniscus that's getting degenerated, that means that meniscus cells are dying. And the thing that causes those cells to die is the forces on those tissues. Okay, so we're having some.
We just want to make sure everybody can hear you.
Okay, we're just making sure everybody can hear. The degenerative process of a joint, it starts out with ligament injury. And we're going to cover this in detail, but joint instability causes arthritis. So that would be something to write down. Joint instability causes arthritis. Ligament injury causes joint instability. And it's actually the ligament injury that causes arthritis pain. There isn't nerve endings in the cartilage. So the cartilage itself, even though the cells die and people are missing cartilage, the cartilage doesn't elicit pain because there's not nerve endings in the cartilage. The nerve endings around the joint are in the ligaments. So it's the stretching of the nerve endings in the ligaments that causes arthritis pain. So joint instability is the number one reason why joints begin to break down. And as you guys know, the traditional model of treating osteoarthritis has to do with stuff that's related to the inside of the joint, like giving cortisone shots or anti-inflammatory medications. And all those things do is accelerate the degenerative process, which I'm going to show you slides and evidence that those types of treatments cause the arthritis to get accelerated. So it speeds up the breakdown of the joint. Whereas prolotherapy stops the actual cause of the joint breakdown, which is ligament laxity or damage to the ligaments. Prolotherapy stimulates the ligaments to tighten and heal. And then we're going to talk about whether or not stem cells injected into the joint are actually necessary or not. Next. Here, that's a picture of Dr. Hemlaw and I in the early 1990s. So he was the world expert in prolotherapy from the 1969 till 1998 when he died at the age of 90. I joined him when he was 83. The picture to your right is Dr. Hackett, who coined the term prolotherapy, and he did a lot of the initial research on prolotherapy. That's Dr. Hackett and Dr. Hemlaw at an academy meeting for physical medicine and rehabilitation, and I'm actually a specialist in physical medicine and rehabilitation. So even in the 1960s at medical conferences, they were talking about prolotherapy. Prolotherapy is an injection technique that stimulates the ligaments to grow and tighten, thus resolving joint instability. Now, the normal tissues of the body heal over a 4 to 6 week period. So prolotherapy restarts the healing cascade so ligaments, cartilage, tendons regenerate over a 4 to 6 week period. Prolotherapy is normally a session of injections, series of injections, and normally it's anywhere from 3 to 8 visits, something like that. Depends on how much joint breakdown is, and there's many different proliferants. Platelet-rich plasma is a proliferant, bone marrow is a proliferant, fat, various types of extracts of fat are a proliferant, but the main proliferant used is hypertonic dextrose. And dextrose is the normal sugar in the body. There isn't a cell in the body that can't live without dextrose. When we eat food, it's basically broken down into D-glucose, or that sugar, and we're using that sugar to restart the healing process. When you sprain your ankle, you get a ligament injury. When you sprain your ankle, the cells release dextrose or D-glucose, and that's one of the stimuluses to get the stem cells, to get the various growth factors there to start the repair process. So that's all we're doing with prolotherapy, is restarting the repair process. Next. And so we're going to show an example of comprehensive H3 prolotherapy. That's Danielle, one of the prolotherapists here at Caring Medical. So we're going to now watch. Now she has platelet-rich plasma, so she's putting platelet-rich plasma into the knee joint here. And you'll see that the process is actually very, very quick. So now she's going to treat the medial collateral ligament. Most arthritis in the knee is from injury to the medial collateral ligament. That's what she's treating there. Now she's using hypertonic dextrose. And again, she's treating the tendons on the side, the ligaments on the side, and then she can do that around the joint. So we call that type of prolotherapy H3 prolotherapy. Dr. Hackett taught it to Dr. Hemwell, who taught it to Dr. Hauser, and of course I taught it to Danielle, so we could call it H3D. But she does a really, really good job, and we see her here. Now she's treating the lateral collateral ligament. And then, of course, prolotherapy can be used for any type of ligament injury, tendon injury, and of course we use it for osteoarthritis and all the injuries of that. Anybody can understand that a degenerated structure needs regeneration. So if arthritis starts with ligament damage, ligament laxity, just meaning the ligaments can't hold the adjacent bones together, then the treatment should be for osteoarthritis something that causes a tightening and a regeneration of the ligament. The only treatment that I know that actually can tighten a chronically stretched out ligament is prolotherapy. Next. Now, a lot of people aren't aware of all the things that joint instability causes. So the body has three mechanisms to stabilize a loose joint. And by a loose joint, I just mean that when a person's walking, for instance, when you have ligament damage in the neck, in the knee, or you have laxity of the ligaments in the knee, when the person's moving, there's destructive joint forces. There's too much motion of the tibia bone and the femur bone. That extra motion causes destructive joint forces, which we'll see on the tissues in and around the joint. Those destructive joint forces ultimately lead to the breakdown of the meniscus, of the bone itself, and ultimately of the articular cartilage. When you have ligament laxity, you have weakening of a ligament. The body's going to do everything it can to stabilize that joint. So the way the body does it is by swelling the joint. Isn't it true that swelling will limit the motion of the joint? So swelling is the body's protective mechanism to stabilize the joint. That diffuses the pressure, so it actually decreases the amount of damage when a person's walking. Thus, using a cortisone shot or anti-inflammatories to decrease that is obviously going to decrease the body's protective mechanism of joint swelling, which is caused by synovitis, which we'll talk about. So that's why taking anti-inflammatories or cortisone shots is actually going to accelerate the degenerative process, because it eliminates the body's protective mechanism. When you have ligament damage in your neck or your back, isn't it true the main symptom you have is muscle tightness or muscle stiffness or muscle spasms? So muscle spasms are the second mechanism by which the body protects the joints from ligament injury. The tone of the muscles at rest is because of the ligaments. So when the ligaments are healthy, the muscles are at rest when a person is walking. But when you have ligament damage, there's a reflex arc called the ligament muscular reflex, which will cause the muscles to tighten. So anybody who has like chronic neck pain or muscle tightness in the lower back that is helped by a massage or helped by a muscle relaxer but just comes again, that's going to be because of underlying ligament laxity. That's why those treatments, massage or even chiropractic care, often it doesn't resolve the issue because there's ligament damage. And until that ligament damage is resolved, the muscle tightness is going to continue. The last method that the body uses to stabilize a loose joint is to overgrow bone. So anybody who has a bone spur called an osteophyte, the cause of that is ligament damage, and the ligament laxity, like when you have ligament laxity and there's too much motion, the body has to do something to limit the motion, because if you have too much motion, the bone is going to hit nerves, is going to hit the spinal cord and different things. So the muscle tightening is to limit that motion so nerves aren't hit. And ultimately, if that goes on for a long enough period of time, you get bone spurs. So bone spurs actually do stabilize or limit motion. So the reason why they don't do clean out procedures like cleaning out the knee, the orthopedists don't do that anymore because it didn't work. Because once you cleaned out the bone spur, the knee became unstable, and then of course the pain got worse. When you have joint instability, you're going to get myofascial restrictions, which can entrap the nerve. So the most common reason why you have a pinched nerve, or nerves are pinched, or a person has radiculopathy, which is the spinal nerves getting pinched, neuralgia, neuritis, is because of joint instability. The nerves of the body run within a few millimeters of the bone, so any kind of extra motion of the bone can hit a nerve. And then also, when you have joint instability, the area between the muscles, that's called the fascial plane, that plane gets restricted, and that can also cause nerves to get entrapped. So the treatment for nerve irritations from joint instability is prolotherapy, because prolotherapy can stabilize the joint and thus stop the destructive joint motions, and then of course the pinched nerve stops. Next. Now, if you think about a kitchen cabinet door, right? When it starts getting loose and it starts jingling, or the door edges start hitting each other. Why do the door edges start hitting each other? They start hitting each other because the hinge is loose, right? So it doesn't make sense if your cabinet doors are hitting each other to actually shave the door or to oil the hinge or replace the door, right? So when articular cartilage starts to get worn out, we shouldn't just do something inside the joint or shave the bone spurs or replace the joint. We should tighten the ligaments, because the bones are rubbing together because of joint looseness. So if you have clicking of your shoulder, you have cracking of your neck, you have cracking of your knees, the cause of it is you got some stretched out ligaments. So the treatment shouldn't be, oh, I'm going to get a hyaluronic acid shot in the knee, or I'm going to get a bone spur shaved, or I'm going to replace the joint, or I'm going to get a disc replacement, or I'm going to get a spinal fusion. It doesn't make any sense. The cause of it is the looseness. So just like with a loose hinge on a door, can we go to the next slide? The treatment's going to be just get a Phillips screwdriver. If you take a Phillips screwdriver and you tighten up that hinge, isn't it true that for the next 10 years you're not going to have a problem with the door edges hitting? So with prolotherapy, once the ligaments tighten up, the joint instability resolves, the swelling resolves, the muscle tightness in the neck resolves, and once the joint's stable, have a nice life. Go exercise, go running, go hiking. Like, you don't need medical care anymore. Next. Here, this is just what it looks like under a microscope. So you see the ligament tissues there. That's actually collagen, and see how it's wavy. So in other words, ligaments can stretch out. They can stretch out a little. They can, like, in other words, those crimps or that waviness, like for instance, when you're running, it can stretch out like about 5%. Once you do something like you're gardening and you're not contracting your core, and then you bend over and you twist, and you don't use your muscles, and then you're forcing the ligament to stretch out more than that 5%, you're probably going to get a ligament injury. Ligaments are amazing. They're only 1 to 3 millimeters in width, most of them, but yet they're gram for gram stronger than steel. So think about that. I mean, they're unbelievably strong. 90 to 95% of ligaments are type 1 collagen. So when we talk about what we're going to do with prolotherapy, the original Dr. Hackett said prolotherapy was fibroblastic proliferation. The fibroblasts are the cells that grow the ligament. So in other words, we're going to proliferate the cells that cause the ligament to make to tighten, and the cells that make the collagen that makes up the ligament are called fibroblasts. And then Dr. Hackett thought of it as welding. So we're actually going to weld or solidify the joint, and then the joint's going to get really strong, and once it's strong, the person can do anything. Ligaments. Yeah, okay, go ahead. There's a question.
Yeah, Dr. Hauser, can you please explain how prolotherapy works with EDS patients with defective collagen?
Okay, so in regard to EDS, so the question was, how does prolotherapy work with Ehlers-Danlos syndrome where they have a defective collagen? If you research Ehlers-Danlos syndrome, you'll see that Ehlers-Danlos syndrome is a genetic condition that normally affects type 3 collagen and type 5 collagen. Ligament tissue is only about 5% type 3 collagen. So in other words, in Ehlers-Danlos syndrome, the type 1 collagen is actually normal. It's just stretched out. The genetic condition where you have a genetic defect of type 1 collagen is called osteogenesis imperfecta. So people with Ehlers-Danlos syndrome have stretched out type 1 collagen, but it's genetically normal. So people with Ehlers-Danlos syndrome heal, in essence, very much like anyone else with a ligament injury because the genetics of the type 1 collagen is normal. The Ehlers-Danlos type 3 collagen and type 5 collagen is in abundant quantity in things like the organs of the body and the blood vessels. So we see a lot of Ehlers-Danlos syndrome. That's actually one of my favorite conditions to treat. I've studied it for like 26 years, so it works really, really good. Most people with Ehlers-Danlos syndrome, the thing that's disabling them is the pain in and around the joints and the instability, so they don't have strength. They lose the ability to walk in that because the joints dislocate. I've seen people with Ehlers-Danlos syndrome that have had 14 surgeries on the one joint. It's ridiculous. It's ridiculous. The thing about prolotherapy, why it's so good, and we'll find out that I call osteoarthritis joint gangrene, because basically once the ligament can't control the forces on the joint because the ligament is incompetent, the joint forces go crazy and all the structures in and around the joint start dying. They start decaying. They start degenerating. And then the terminal knee, the knee where everything's destroyed, the orthopedic surgeons do what? They amputate the joint. That's what a joint replacement is. They're actually cutting out various parts of the knee or the hip, like the ball. They actually cut out the whole ball, then they replace it. So that's an amputation. So joint replacement is an amputation of the various parts of the joint, and they're replacing it with metal and plastic parts. Prolotherapy stimulates the tightening of the ligament, and once that ligament tightens, then the arthritic process stops. And then, of course, regeneration can occur in structure size of finger joints. Normally, the finger joints are big because of synovitis. So we're gonna talk about synovitis. That'll be in a few slides. And then because prolotherapy resolves the joint instability, there's no more reason for the synovitis. And once the synovitis goes down, so does the size of the joints. Now, I want to just continue here. The ligaments contain most of the nerve sensors of the joint. So in other words, what tells the brain where the joint is in 3D space is the mechanical or proprioceptors in the ligaments. So the ligaments, when your joint hurts, it's because of the stretching of the nerves in the ligaments. When a ligament is really strong, the nerves within the ligament can't stretch. When a ligament is lax, the nerves get stretched, and that's what causes the pain of osteoarthritis. Okay, next. Now, I put this in there. We see so many people after joint replacements. I can't tell you how many people have pain after joint replacements. So you see here what says the strength of cobalt or titanium is, let's just say, 750. So the strength of titanium is 750, but the strength of tendons and ligaments is only 25, let's say. So, and there's various nomenclature that we use, you know, pascals or newtons. But if you take 750 and 25, so the difference of that is what? 4 times 7.5, so it's 30. So let's agree that the joint replacement is 30 times the strength of the ligaments. The joint replacement is 30 times the strength of the ligaments. So what's going to happen when you have a joint replacement and you're walking? Where's the force going to go? The force is going to go all on the ligaments. And we see so many people with joint instability after joint replacements. Or if you've had a joint replacement and you're like, doctor, something's not right. Like it's clicking, it's popping, my joint replacement, it's hurting. That's because of the ligament laxity. Either it occurred during the joint replacement, because during joint replacements or arthroscopy, they have to open up the joint, right? They have to open up the joint. So during arthroscopy, for instance, they push liters and liters of fluid inside your knee or your hip. They, you know, under pressure, you know, liters and liters of fluid. And do you know the knee joint and the hip joints only normally contains 1 to 3 cc's, 1 to 3 cc's of fluid. But when they do an arthroscopy, they're pushing thousands of liters of fluid under pressure in the knee joint, in the elbow joint, in the hip joint. So that stretches out the ligaments. So what causes pain that's worsened by arthroscopy or after arthroscopy is ligament laxity. Or if you have a joint replacement and you have pain after that, it's because of ligament laxity. So you have to get prolotherapy because that's the only treatment that tightens a chronically stretched out ligament. Next. So okay, this is interesting too. So we had the question about the hands. So they did a study where every year they started doing MRIs of people's hands. So they didn't have any symptoms. They were trying to figure out what's the very first thing that shows up on MRI. What's the very first thing that shows up on MRI that causes osteoarthritis of the fingers? And the very first abnormality that they found out was where the ligament attaches to the bone. So in the collateral ligament of the finger joints, the very first lesion is an abnormality, a degeneration in the ligament bone interface. And thus, the very first physical finding is tenderness where the ligament attaches to the bone. That's the very first physical finding when somebody has ligament damage. And then eventually you get hypermobility in that joint. You get hypermobility. So for instance, if the middle finger, a person has swelling right there, you can bet you have joint instability there, and the body's swelling that joint, that's causing the joint to puff up. And then you know that the degenerative process is well on your way. The treatment of that is you got to get the ligament tightened. Now the neat thing is we have ultrasound now in the office, so we can see the looseness in the joint. Now in this slide I say that the ligament, meniscus, bone marrow precedes cartilage deterioration by 2 to 5 years. Now that's predicated on the person's not doing crazy activities, because if you got a loose knee and you're just taking ibuprofen and you're going to play tennis, you know, you could get cartilage damage within a month of that. But just normally, ligament damage, meniscus damage, bone marrow lesions, those things precede the cartilage damage by about 5 years. Then you start seeing the cartilage starts getting less and less and less and less. Okay, next. Now on ultrasound, see that blackness there? This is a ultrasound, what it looks like under the ankle ligament called the anterior talofibular ligament. So we see, like I did a bunch of ultrasounds today on degenerative joints today, and we're looking for those black areas. That's a tear. So the person has a tear in their ligament there, and of course, the treatment of that is prolotherapy. Once that ligament is tightened, the person regains the stability of the ankle, and then of course the degenerative process stops. Next. Now, we normally grade ligament injuries by grade 1 is a sprain, grade 2 is normally a partial tear. That's what you saw in the ultrasound there, partial tear. And then there's complete tears. Certain ligament injuries, if they get a complete tear, like if you get a complete tear in the ankle ligaments, you still can get prolotherapy and it works great. When you get a complete tear of a ligament such as the anterior cruciate ligament of the knee, that's normally the kind of ligament injury that requires surgery. So there are ligament injuries that do require surgery, and the knee, when you get a complete tear of the anterior cruciate ligament, that's one of them. Next. Now I should say that many of patients get those, like a repair of the anterior cruciate ligament, but then it starts to wear off, and then they need prolotherapy. So I'm going to show you how we assess for joint instability in the office. So that's me. You know it's me because I love the color yellow and I love Minions. So that's me with my. So this is how we're going to see instability of the knee. So you see I'm doing a stressor. See how it opens up there? That's what we see. So you could see how much it opens up. So we can measure how much it opens up, how much is the ligament laxity, and that's what it looks like after prolotherapy. It's much, much tighter. And once the painful knee is as tight as the non-painful knee, then the person's cured of their pain and they shouldn't need any prolotherapy in the future, given that they exercise with good form. They're running with good form, they're weightlifting with good form. So this is a really interesting slide. So in this slide, what the researchers are doing is they're slowly stretching the anterior cruciate ligament. Now the anterior cruciate ligament is 2.5 inches long. So it's 2.5 inches long, or 40 millimeters. And this is the force on the ligament, and it's how much it's elongating. So if you look at that, the difference between a completely stable knee from a really tight anterior cruciate ligament to one where it's completely torn is only what, 3 millimeters, right? 3 millimeters. Now at some point the ligament's completely going to break. So the prolotherapy zone, if you will, is within those 3 millimeters before it breaks. So when we say we're tightening the ligament with prolotherapy, we're tightening it 1 millimeter, 2 millimeters, 2.5 millimeters. So that's all it is. The difference between feeling awesome in your knee, awesome in your hip, awesome in your ankle, and not having any pain is only the difference of extra laxity, extra motion in a ligament by 1 millimeter, 2 millimeters, 2.5 millimeters. That's it. Next. So when you have ligament laxity, the ligament laxity causes a synovitis or swelling in the joint. Eventually, the ligament laxity causes joint instability. Once you have joint instability, say on the inside of the knee, the forces get directed to the inside of the knee, then eventually you're going to get lesions on the bone marrow. You'll get cysts on your bone marrow. You'll get edema in your bone marrow. So if you've had an MRI and it showed edema in the bones of your spine or your shoulder or your knee, that's because of destructive joint forces from ligament injury in those areas. So that's all it means. So all you need to do is get prolotherapy in those areas. Those joints get stabilized. Then the bone marrow edema will go away. Eventually, if the forces don't go away, like you don't get prolotherapy, you continue to exercise, you take pain pills instead of getting the underlying osteoarthritic condition resolved with prolotherapy, then you'll eventually get cracks in your articular cartilage, and eventually the ligament cells will die, the fibroblasts, the tendon cells will die, the tenocytes, the articular cartilage cells, the chondrocytes will die. Once they die, they can't make cartilage tissue, they can't make tendon tissue, they can't make ligament tissue. So it's like a catch-22 process. The body loses its ability to repair itself, so thus you need regenerative injection treatment or prolotherapy. And we'll talk about when to use dextrose, when to use PRP, when to use stem cells. Next. You have another question?
Yeah, what is the general expectation for how long prolotherapy takes to repair
Okay.
a patient?
How long does prolotherapy take it to repair? The repair actually starts immediately. So it's actually, most people feel better even with the first treatment. Okay. Normally when people don't respond to prolotherapy, like apparently the person's asking the question had 2 treatments, didn't feel better. Normally it's because the person doing the prolotherapy is not treating the joint comprehensively. For instance, in other words, like prolotherapy is a lot of injections. You have to thoroughly treat the whole ligament. So if you have, like say for instance, if it's the medial side of the knee or the lateral side of the knee, you have to treat it comprehensively. And so that would be the first thing. Make sure that the joints, the ligaments getting treated comprehensively. The second thing you have to realize is most people go to a prolotherapist. The condition's been going on for 10 years, 8 years, lots of years. So the amount of degeneration is so extensive that it may take a prolotherapist 3 treatments, 4 treatments to get somebody from severe instability to moderate instability. And then you also have to remember you have to put the right amount of forces on the ligament while you're getting prolotherapy. So for instance, I'll have patients who they have severe instability, but they still play tennis. They still do way too much. They do way too much. So if you get prolotherapy, you really got to make sure you know what to do and what not to do. So here, this is just a figure on an osteoarthritic joint compared to a normal joint. So an osteoarthritic joint often has a bone spur where the instability is. They have inflammatory joint fluid. So that inflammatory joint fluid can cause problems long term. And then they have meniscus and bone marrow degeneration. Next. So here, I just want to remind people, the normal joint only has 1, 2, 3 cc's of fluid. So if you have a joint that looks big, you got too much joint fluid in there. The joint fluid is inflammatory. So the way to resolve that is you got to resolve the reason why the joint's swollen, and that reason is joint instability. Next. This is kind of a complicated slide, but it just says that you can have malalignments of bone. So for instance, myself, if I could show you, I was born with a crooked right foot. It points out. I was born that way. So because I have that malalignment, that causes me to have more forces on my ankle, on my knee. So eventually I got instability of my ankle and my knee. So I had prolotherapy on my ankle. That was one of the first areas I had treated. I had 3 treatments on my ankle, and that was basically back in '94. So I've been fine for 25 years, and I've done 5 Ironmans and probably 25 marathons. So in other words, prolotherapy absolutely lasts, and you can't blame like pain on a malalignment. A malalignment just gives you more stresses in a joint. Now, I said that my malalignment of my foot caused me to have more stresses on my knee. My knee didn't bother me till 2008 after I did my 5th Ironman. In 2008, I had 4 stem cell treatments with prolotherapy on my right knee. My right knee was completely fine till 2018. Then I had 3 regular prolotherapies. Sorry. And then I've been completely fine since. But remember, I'm a runner, so I'm not easy on my knee. So I'm running around 20 miles a week, basically. All the time I run it. So that's like every week. Next. This again goes over that joint instability eventually leads to the breakdown of the joint structures. And a person who has stiffness in the joint, traditional medicine gives them high hyaluronic acid. If the joint instability causes a nerve pain, the doctor might recommend radio ablation where they freeze or they fry the nerve. Obviously, that's not going to cure the pain. When a person has muscle spasm, like in the neck, some doctors do botulism toxin injections, Botox. I wouldn't do that because the muscle tightness is actually what's protecting the disc and protecting the spinal cord and the various nerves. So when I see somebody after they've had Botox injections, it's not good because they don't have the muscle tightness here, then the ligaments get even stretched out further. So I'd really recommend people don't get Botox for pain because you're actually eliminating one of the body's protective mechanism, which is muscle tightness. Massage therapy is great. Muscle relaxers can work, but they don't resolve the underlying joint instability. That's why very few people get cured by massage therapy. When you have synovitis means that the joint's producing too much joint fluid, and the synovium, which is the joint lining, is all inflamed. So when you have joint instability, the synovium is going to be under stretch. So remember, the joint synovium, the joint lining, are the cells. The synovial cells are what make the joint fluid. They make the joint fluid in response to motion. So that's why when you have osteoarthritis and you go cycling or you do swimming or you do motion, you feel better because it's the motion that causes the joint fluid to be made by the synovial cells. When you have joint instability, the synovial cells are under stretch all the time. That's why they keep producing joint fluid, and when the joint is full of fluid, that hurts because it's full of fluid, so the ligaments are under stretch, the synovium's under stretch. So when you take an anti-inflammatory or you get a cortisone shot, you do feel better, but again, it's not a good solution because cortisone is damaging to the cartilage cells, it's damaging to the ligaments, it's damaging to the joint capsule. It eliminates the body's protective mechanism, and of course, you get accelerated arthritis. Now, when you get bone spurs forming, of course, or you get disc degeneration, orthopedic surgeons want to take out the bone, they want to do arthroscopy. One of the very quickest ways to get arthritis in a knee joint is to get arthroscopy in the knee joint. I wouldn't recommend arthroscopy unless you had a complete anterior cruciate ligament tear. It's a terrible solution, and it's going to accelerate the arthritic process. Like, think about it, like, why in 2019 are knee replacements, hip replacements at an all-time high? Like, why? The main reason I think it's why is because people with pain, they go to orthopedic surgeons. Like, orthopedic surgeons, in their armamentarium is arthroscopy, and they'll find a way to do arthroscopy. So what a person needs when you have damage of a joint, that means the ligaments, the meniscus, the bone marrow, it's degenerated, it's damaged. And damaged means degeneration. A degenerated structure needs regeneration. Who a person should be seeing is somebody who's an expert in prolotherapy and regenerative injection therapy. Next. So this is what happens. These are all the things that happen when you get a ligament injury. When you get a ligament injury, the forces on the knee go way, way up. And I'm using the example of the knee, but it's all the joints where there's a ligament injury. So we're going to use the knee as the example. When you get a ligament injury on one side of the joint, the forces go toward that side of the joint when you're walking. So a knee that's stable, the joints, the forces are more diffuse on the joint. But when you have a ligament damage, say over here, the forces, instead of being in the middle of the joint, they go toward that part of the joint. So instead of the joint forces going over a big wide area of the joint, they go through a really, really little part of the joint. And that's going to be where the meniscus tears, where the articular cartilage tears. So that's why a person gets a meniscus tear. 90% of meniscus tears occur on a meniscus that's already degenerated. Over 90% of ligament tears or tendon tears occur in an already weakened, degenerated tendon or ligament injury. So the treatment should be not take out the meniscus, because you need your meniscus to cushion and stabilize the knee. You need to get prolotherapy to stimulate repair of that meniscus, repair of that ligament. Next. Now, if you do decide to get a meniscus taken out or part of the meniscus taken out, the forces on the knee go crazy. That's why that operation, they don't even like to do that operation too much anymore. It's a terrible operation. It definitely accelerates the arthritic process. The forces go crazy. Like if you get your meniscus out, the forces on your knee when you're walking is going to go up 7-fold. It's terrible. You need to try to keep your meniscus. You got to try to keep your meniscus, and the way you try to keep your meniscus is with prolotherapy. When I treat a meniscus tear, I like to use platelet-rich plasma, because platelet-rich plasma is more gluey for the tear. So tendon tears, ligament tears, we often do use platelet-rich plasma because it works really good for tears. Next. Now these are bone marrow lesions. So those are little cysts, edema. When those show up on MRI, it means that there's too much force. If you don't eliminate the force on the bone, eventually there's going to be a condition called avascular necrosis. The cause of avascular necrosis or bone death is basically too much force on the bone because of joint instability. So osteoarthritis dissecans, which is where the cartilage gets damaged and basically the cartilage starts to die. That's because of joint instability. And then bone marrow edema, bone cysts, avascular necrosis, those conditions are caused by joint instability causing too much force on the bone. So the treatment for avascular necrosis, bone cysts, bone marrow edema, osteochondritis dissecans, where the cartilage is starting to die, is prolotherapy, because prolotherapy can resolve the joint instability that's causing those conditions. Next. This just shows that bone marrow edema, it precedes the development of articular cartilage damage. So the more there's bone marrow edema, the more in the future, and a lot of these studies are done like people don't even have symptoms, and they're just trying, and they don't have symptoms, they don't have articular cartilage damage, and they're just following the patients over time and seeing who develops articular cartilage wearing. And you know that by the joint space between the bones goes narrower. So that's how you know the articular cartilage cells are dying. And bone marrow edema, bone marrow lesions, the more severe they are, the more there's articular cartilage damage and wear, like 2 years down the line. So meniscus degeneration, bone marrow degeneration, bone marrow edema precedes articular cartilage degeneration, and joint space narrowing by a year, by 2 years, by 3 years. Next. Then this is what I was trying to illustrate, where when you have ligament damage, the joint forces go toward the ligament damage. So that's what I mean when you have ligament damage, you get destructive joint forces, and those destructive joint forces end up going on a very small area of the joint, and that's where you get the cartilage wears out, the chondrocytes, the articular cartilage cells start dying, as well as the meniscus cells, and then eventually they can't make meniscus tissue or cartilage tissue, and then you get a weakening of those tissues, and eventually the tissue dies, and then you get a bone-on-bone situation. Next. This just shows when you get ligament damage, the meniscus extrudes outside the joint. Yeah, you get the meniscus extrudes outside the joint. That's what we see when I do ultrasounds, or we do ultrasounds in the office here. Meniscus degeneration, extruding discs, extruding or protruding meniscuses, they protrude or extrude because of ligament laxity. Next. So unresolved joint instability eventually causes massive joint cell death, which we know as osteoarthritis. Next. Now, with one cortisone shot, you can get fibrillation or cracking of the articular cartilage. This is an animal study just after one steroid shot, so don't get steroid shots. They cause the death of articular cartilage cells, and you get cracking. Once you get cracking, the permeability in the articular cartilage goes up, and basically the cartilage cells drown to death. That's what actually causes their death. Next. This is basically showing that eventually when you get fibrillations or fissures in the articular cartilage, it eventually goes down to the bone, and then you're going to get advanced osteoarthritis. Next. This is basically, so when you get ligament damage, causes unbelievable forces to occur on the articular cartilage. The articular cartilage eventually cracks. The joint fluid rushes in to the articular cartilage, and basically the chondrocytes drown to death. The chondrocytes basically, they start swelling, and eventually they burst and they drown to death, and that's what causes the cartilage cells to die. So it's kind of interesting that the person has a bone-on-bone situation because the articular cartilage cells died. Next. And this is what it looks like under arthroscopy. That's an area where there's no cartilage. That's actually what it looks like under arthroscopy. But I can tell you, with bone marrow, with lipoaspirate, with stem cells, with platelet-rich plasma, you can absolutely cause articular cartilage to regenerate, but you have to resolve the joint instability, and you do that by prolotherapy. Next. Keep going. Okay, this is what it looks like under ultrasound. The top one there is actually my knee. So in other words, my knee, the normal amount of articular cartilage is 3 millimeters. So you could see that on my lateral side I have 3.2, on my medial side I have 2.2. And this is what it looks like under ultrasound in an office setting where a person has bone-on-bone, no articular cartilage. So the articular cartilage in this particular person died because there's too much force from joint instability. So the way to solve this problem is not just to inject stem cells into the joint. Because if you just inject stem cells into the joint, you don't resolve the joint instability, the stem cells are going to have the same fate as the articular cartilage cells. So in our office, often we'll tighten up the ligaments, and then we'll start stem cell therapy, with bone marrow, with PRP, or with lipoaspirate. But you have to resolve the joint instability for stem cell therapy in most cases to work. You have to do comprehensive prolotherapy or H3 prolotherapy into the ligaments, and then once the joint's more stable, the stem cells then can turn into cartilage cells, and eventually those cartilage cells make articular cartilage. So in the office, we can use ultrasound to document the improvement of ligament health, tendon health, articular cartilage cells health, to make sure that the person's responding to prolotherapy, PRP, bone marrow prolotherapy. Next. So this was just, we did some, this is interesting. We looked at how many articular cartilage cells there are and what happens with them when you have joint instability. As it turns out, if you have mild joint instability of the knee, you're going to kill one articular cartilage cells by 100 steps. If you have severe instability of the knee, it's only going to take 17 steps and one articular cartilage cell is going to die. So that's why if you have severe knee instability and you're getting treated with prolotherapy, we might have to put a brace on you, until your joint's a little bit more stable, before we allow you just to walk. So just know, all you people who do 10,000 steps or 5,000 steps, and if you have joint instability, man, you're just killing one articular cartilage cell after another, after another, after another. So that's why you can't just take anti-inflammatory medications or Tylenol or narcotics or muscle relaxants and then go walking. You're just causing more and more death of articular cartilage cells. Next. This is what a completely destroyed joint looks like. So see, this person doesn't even have a ball of their hip anymore, so they need a new ball put in there. So this particular patient, they came to see us, but nope, you need a joint replacement. The only way you're going to get a ball in there again is to replace it. Next. So disc deterioration and joint deterioration, it's the exact same process, starts with ligament injury. Eventually in the discs, that the excessive movement because of joint instability, the discs in between the two vertebrae, the cells are going to degenerate, the cells are going to die, and then you're going to get disc degeneration. So the cause of disc degeneration, arthritis in the neck or arthritis in the spine, is also ligament injury. And the treatment of choice should be prolotherapy. And prolotherapy can then stabilize the joint in the neck or in the back and resolve the pain. Next. Okay, let's go next. And this is kind of just shows the process that eventually when you have ligament injury, the ligament injury is going to cause more forces on the adjacent bone. This is picked up on x-ray by the x-ray showing the bone is wider. That's why you have those white areas on the bone. That's called sclerosis. That means there's too much force on those areas. Then eventually, if the force isn't resolved, eventually you'll get disc degeneration, and then eventually you'll get bone spur formation. And that whole process can be stopped with prolotherapy. Next. And then this is what joint instability looks like in the lower back. You could see that the vertebrae aren't aligned, and then there's forward slippage of the vertebrae. The forward slippage is because of ligament laxity in the back of the back of the vertebrae. So prolotherapy to those ligaments will tighten it, and then it'll help get rid of that pain. Next. So the new model of osteoarthritis is osteoarthritis starts with ligament injury. Ligament injury, if the condition progresses, you're going to get edema in the bone. You're going to get altered joint mechanics. You'll get sclerosis or thickening of the bone. Then you're going to eventually get cracks in the articular cartilage. Then the articular cartilage cells die. Next. Then this is one of the scanners that we have to show instability of the spine. So we actually, how can you tell if your kitchen cabinet door is loose? Don't you have to move it? So why MRIs and X-ray, traditional X-rays, don't show instability of the joints is because people get those MRIs and the X-rays with them laying down. So we scan people when they're moving. So next. So we're going to show a scan, a digital motion X-ray of a spine. But what happens in the neck, for instance, is when you get ligament damage in the neck, you actually lose the curve of the neck. The curve actually gets reversed, so the forces on the ligaments even get greater, and eventually you get complete collapse or destabilization of the cervical spine. And besides osteoarthritis, that causes migraine headaches, dizziness, vertigo, swallowing difficulties, poor balance, mental fatigue, dysautonomia, POTS, mast cell activation syndrome. So if you have any of those things, it's all caused by the same process, which is joint instability in the neck. You need to get a digital motion X-ray, and most likely, if it does show the instability, you're going to need prolotherapy stabilization of your neck. Next. Here, I just want to show a digital motion X-ray of a neck. So this is just, pinched nerves are a major problem when you have arthritis in the neck or you have arthritis in the back. So this is kind of what it looks like under digital motion X-ray. So see those openings. Those openings are where the nerves are coming up. And see how you get closure. See how that one opening closed? Watch it again. It opens when the person bends forward, then it closes when it's up, but the other ones stay open. So that means that it's closing because of ligament damage. It's closing because of ligament damage. So if we do prolotherapy where there's ligament damage, it's going to stay open more. So this was after 2 visits. The person's symptoms were like 80% better. See how it stayed open, but it's not all the way open? But the person didn't even want me to treat him, but it's not all the way open yet. And their symptoms weren't totally gone. So I recommended 2 more visits, which we did 2 more visits. And then we can use the ultrasound or the motion scanner to document the joint stabilization. And in this particular case, that now the nerve has plenty of room. The nerve has plenty of room. And then this particular patient, I think this was like about 2 or 3 years ago, and then they haven't seen me since then. They've been completely fine. So once the joint gets stable, pinched nerves go away, the pain goes away, and then if people in their necks, they have migraine headaches, they go away. And as long as the joint stays stable, they're going to be, they'll be fine, and the pain isn't going to recur. Next. And we're going to go to the next slide. So the ideal osteoarthritis treatment would get at the root cause of osteoarthritis, which is ligament laxity. Next. And then this is what prolotherapy causes. So you get degeneration of the ligament, then you induce an inflammatory reaction. So see all those cells, that's the fibroblastic proliferation. So after prolotherapy, there's massive influx of stem cells, growth factors, fibroblastic proliferation. Now, I look at fibroblasts as carpenter cells. So it's like if you have if you have a kitchen remodeling project and there's 1 worker, they're going to get more or less work done if there's 5 workers. So obviously, when there's 5 workers, or 5 times as much work is going to get done on your kitchen. So prolotherapy causes a massive influx of worker cells, and those worker cells start rebuilding the ligaments by putting in collagen, so the ligaments become thicker and stronger. Next. So this is kind of illustration. So to me, I'd rather get prolotherapy for osteoarthritis than get an artificial knee. So artificial knees are a big hunk of metal. So if God wanted our knees to have a big hunk of metal in them, he would have made them that way. Next. What about stem cells? This is all cracked up to be. Next. There's different, this is an interesting slide. So, this is just a kind of a slide we made up that it's 2 mothers talking about their kids, and the one says they would much rather have their kid be a ligament cell than a cartilage cell. Ligament cells are much more important to the joint than a cartilage cell. So we got to stop this whole fanaticism on cartilage. The pain from arthritis, so I'd write this down, arthritis pain is from ligaments. Arthritis pain is from ligaments. What causes the joint to degenerate is weakness in the ligaments. We could call this ligament laxity, ligament incompetency, and when those ligaments can't control the motion of the bones, then you get destructive joint forces, and those joint forces lead to the breakdown of the joint. But the cure for arthritis pain, the cure to stop the arthritic process, is prolotherapy by tightening and strengthening the ligaments. Once the ligaments are tightened and strengthened, the joint is stable, and a stable joint doesn't have pain. An unstable joint has pain. It's as simple as that. So if you got joint pain, it's from an unstable joint. The way you can show that the joint's unstable is get an ultrasound, move the joint. You'll see that it opens up, just like I showed on that ultrasound. Or if you got spinal pain, get a digital motion x-ray or get a motion x-ray. And then that'll show the instability. And once that instability is resolved with prolotherapy, you'll see that the nerve pain, the disc pain, the ligament pain, it all goes away. Next. And then this is interesting. After a ligament injury, the amount of stem cells go up like unbelievable amounts, like 1,000 times. 1,000 times more stem cells in the joint after ligament irritation. So I can guarantee you that when you have a ligament injury, like you sprain your ankle, the body's mobilizing so many stem cells. The stem cells that are in your ligaments, the stem cells that are in your synovium, the stem cells that are in your bone marrow, the stem cells that are in your joint, those all get mobilized with a ligament injury, and they also get mobilized when you get prolotherapy next. Then this just shows that when you have osteoarthritis, this is interesting, when you have osteoarthritis compared to a normal joint, you actually have more stem cells in the arthritic joint. So arthritic joints have more stem cells than a non-arthritic joint. So it isn't a stem cell deficiency problem, it's a stem cell proliferation problem. In other words, what's causing the stem cells, all these stem cells in an arthritic joint, to not grow cartilage, to not grow ligaments? And the cause of it is the stem cells have too much force on them. What determines what a stem cell does is the force on it. A stem cell can die, so if there's too much force, the stem cell dies. If there's the right amount of force on a stem cell, it's going to form another stem cell, and it's going to change into like an articular cartilage cell. So if the right amount of force is on the stem cell, it's going to grow cartilage basically eventually. It'll change into a cartilage cell or a ligament cell or a meniscal cell. But if there's too much force on it, which of course, when you have joint instability, there's too much force on the stem cells, so they don't turn into cartilage cells like they should, so you don't get cartilage regeneration. So the most potent stem cell procedure is prolotherapy. That's why there's so many people out there that spend a lot of money getting one shot of stem cells into a joint, and they're like, geez, that was a quick $5,000, $8,000, and it didn't help. Well, the reason why it doesn't help is because the stem cells got destroyed in the same manner in which the articular cartilage cells got destroyed, because there's too much force on them because of excessive movement from joint instability. So before somebody spends a lot of money on a stem cell procedure, you have to get assessed for joint laxity, and if you have joint laxity, the ligaments also have to be treated. So the ligaments have to be treated because that's the cause of the articular cartilage cells dying. That's the cause of the stem cells that are already in your joint not working. So that the treatment isn't, oh, I need young stem cells. No, the young stem cells are going to die too. So there's so many people out there that got temporary relief with stem cell therapy, but it didn't cause any long-term relief. And the reason why it didn't cause long-term relief is because the joint instability was never resolved, because you can't resolve joint instability unless the ligaments are tightened. And that's what prolotherapy does. Next. This just shows that if the physical forces are too much on a cell, the cell isn't going to produce all the things that the cell needs to produce. Oh, I said stem cells can die. That's if they get too much force. If they get the right amount of force, then they're going to make growth factors, right? They're going to make growth factors, and those growth factors will attract other stem cells. And then, of course, with the right amount of force, the stem cells can turn into a cartilage cell, which can regenerate cartilage, or the stem cell can replicate itself by another stem cell. Next. Then comprehensive prolotherapy works on all the different parts of what causes osteoarthritis. So when a person gets prolotherapy, the abnormal inflammatory synovial fluid gets to normal. Then the subchondral bone, the forces go away from that, so the bone cyst and the bone edema goes away. The articular cartilage cells then start replicating, making articular cartilage. So then the forces on the bone, on the joint get back to normal, and then the pain goes away, the inflammation goes away, the tissues get their strength back, and of course, once they get their strength back, man, you can go hiking, you can go running, you can go swimming, your shoulder works again, you can lift weights again. So all these things we talk about in the visit, but prolotherapy restarts the healing cascade. And as long as the ligaments are treated and they're allowed to heal, so you have to have the right forces on them while they're healing, then after a series of treatments, eventually the joint regains its stability, and then the person has hopefully unrestricted activities that they're able to do without pain. Next. So how do you choose what solution to use? I often say this, which is that the most important proliferant is actually where the needle is placed. So obviously choose your prolotherapist wisely, but if a person has a mild ligament injury, regular prolotherapy with the hypertonic dextrose works great. Once there's a really severe ligament injury, such as a tear, or a person has a labral injury, labral degeneration, or a labral tear, the labrum is a cross between articular cartilage and ligament tissue. So it's fibrocartilage. And the labrum is in the hip, is in the shoulder and the hip. So anybody with a labral tear, I would use personally platelet-rich plasma, ultrasound guided into the labrum or into a tendon tear or ligament tear. And once there's an osteochondritis dissecans lesion or avascular necrosis or a really big osteochondral defect, or there's a bone-on-bone situation, at some point we'll use bone marrow or fat and get the stem cells out in those areas. But again, you still have to do comprehensive prolotherapy, H3 prolotherapy around the joint. Next. And this is me basically getting out bone marrow from the person's iliac crest. So that's basically the procedure. We can get bone marrow from the shin bone, the tibial bone, or the iliac crest, and then we drill into the bone, take out the stylet, and then we withdraw the bone marrow. And even today, I had a patient where I took out many syringes, like lots of syringes of bone marrow, and we used that as the proliferant. So I did write an article, which is available at caringmedical.com. We have all of our research articles. I've written probably about 30 different articles on prolotherapy, had them published. One of the articles discusses why I think bone marrow is the ideal proliferant. So there's people with Ehlers-Danlos syndrome, joint hypermobility syndrome that have pain all over their body. And often I'm asked, can you get prolotherapy all over your body? We definitely have people where we use bone marrow and we use it as the proliferant for all the body parts. Some of the patients get so many body parts done that they actually do it over the course of 2 or 3 days. You definitely, can get prolotherapy in multiple body parts at a visit. Next. Then stem cells can turn into labrum, cartilage, meniscus, muscle, bone, tendon, ligament tissue. So the goal of stem cell therapy is to replenish if there's a lot of tendinosis, like there's a lot of tendon tissue missing, or there's a lot of ligament tissue missing, or there's a lot of cartilage tissue missing. So we're using the stem cells to replenish those cellular stores because there's a cellular deficiency. And then as long as the forces on the tissues are reasonable, because the ligaments are tightened with prolotherapy, the stem cell therapy is going to be effective.
Okay, we have a question about prolozone and your thoughts on B12.
Okay, there's lots of different proliferants. Like even today I used ozone. I used ozone as a proliferant. Ozone is a really strong oxidant. So when you oxidize the joint, that also adds a type of proliferation, right? We often talk about inflammation, like when you injure tissue, like when you sprain your ankle, what happens is the body mounts an inflammatory reaction to stimulate healing. Well, in that inflammatory reaction is oxidation. So ozone can be used as a proliferant, works very good. Normally, if you have a lot of joint instability, ozone in and of itself is not a strong enough proliferant to cause tightening of the ligaments. But There's definitely good studies on disc degeneration and different kinds of spinal conditions, but I use ozone as one of the proliferants, but by itself it normally isn't strong enough to cause enough ligament healing to resolve joint instability. And then you had one other question. Oh, B12, yeah. Some of the doctors use B12. Yeah, B12 can be used as a proliferant. Some of the other proliferants that I use is magnesium. There's good studies on magnesium and cartilage. We sometimes use manganese. We use various substances to attract platelets. So some of those substances are, one of them is a sclera that will attract the platelets. So we have lots of different proliferants. But remember, it's not mainly the proliferant, it's the proliferer. It's the doctor doing the injections. That's the most important choice, because you could use the greatest, most concentrated stem cells, but if the doctor doesn't use those cells into the ligaments and you don't get joint stabilization, by the tightening and thickening of the ligaments, the strongest proliferant in the world isn't going to work. So the most important thing is choosing the right injector. Next. This is a study that we did on when we used bone marrow into the joint and we used dextrose prolotherapy around the joints. Remember I said stem cell therapy is going to be effective for osteoarthritis if you also inject the ligaments. So this study was on advanced osteoarthritis. You guys can read this at caringmedical.com. I was the lead author, Ross Hauser, and I wrote the paper with Barbara Walden. So if you Google that or you go to our site, look at our research. But there was 24 end-stage osteoarthritic patients. 16 of them were supposed to get, by the orthopedic surgeons, recommendations of joint replacements. These were people that said, nope, I don't want metal in my body. Then a couple more people were supposed to get their meniscuses out, but all of the cases were end-stage osteoarthritis. So I assessed them that they were good prolotherapy candidates. So it meant that they had reasonable amounts of motion. The hip joint ball, it was still a ball. It wasn't like flat on one side. It was still a ball. It was still a ball, so it wasn't flat on one side. Once it's flat on one side, you got to get a hip replacement. So in other words, they exhausted conservative care. Basically almost all the patients were told they need surgery. 16 of the 24 were told they needed a joint replacement. 2 of the patients the orthopedic surgeon wanted to do meniscus surgery, and I, did an analysis. They were excellent candidates for prolotherapy. In our experience, when somebody's an excellent prolotherapy candidate, even if an orthopedic surgeon said they needed a joint replacement, our success rate is 9 out of 10. And in this study, look at this study, pain with exercise on a scale of 0 to 10, scale of 0 to 10, they were 6.33. When we got done with about 4 stem cell prolotherapy visits with bone marrow, so they only needed about 4 visits, the pain with exercise, with running, with cycling was only 0.5. So basically they were cured of their pain. So the results are spectacular. Their pain at rest went from 4.6 to 0.2. Pain with normal activities went from 5.9 to 0.4. And pain with exercise went from 6.3 to 0.5. So I can tell you, even with end-stage osteoarthritis, as long as the ligaments are treated, you can absolutely get back to exercise. In 2007, so that's going on, 12 years ago, just for fun, what we did at the office was the first 34 patients that were told by an orthopedic surgeon or a podiatrist that they needed surgery for their pain conditions, I then followed them long term. So I followed them long term. And do you know, when it was all said and done, 31 out of the 34 didn't need surgery after prolotherapy. So that's why I say, when I say that 9 out of 10 people won't need surgery once they're assessed and found to be an excellent prolotherapy candidate, we have the research to prove it, as well as 27 years of experience. And if somebody has a totally destroyed joint and they're not an excellent candidate for prolotherapy, us at Caring Medical will absolutely tell you got to get surgery. So we're not afraid to do that, and we always want our patients to get the best possible care. Most of the time, the best treatment is prolotherapy when prolotherapy isn't. We'll definitely recommend fusion surgery or joint replacement or whatever surgery is needed. Next. We also looked at 69 patients of ours who had cartilage deterioration behind the kneecap. So that ultrasound I showed where the person was bone on bone with the ultrasound, that condition is called chondromalacia patella. Chondro means cartilage, patella means kneecap, and malacia means damage. So damage of the cartilage beneath the kneecap is called chondromalacia patella. If you have clicking, grinding, popping of the knee, like when you move it and it's been going on for a while, I can tell you for sure you got chondromalacia patella. So again, we did on average, about 4 visits of prolotherapy, and you can see here that the clicking or crepitation went down, stiffness went down, pain with exercise went from a 6.5 to a 1.4. The pain at rest went 2.9 to 0.4. The pain with activity went from 4.9 to 0.8. You always got to remember too, like you might say, well, the person still had a pain level of 1.4 after your prolotherapy. But you understand the patients choose to stop treatment. So there's plenty of patients, like if you had a pain level of almost a 7, like you couldn't do any exercise, then you got 4 prolotherapy visits, and now your pain level's a 1 or a 2 with running. You might say, geez, I'm really happy with the results. So sometimes what it is the patient decided to stop treatment because they were happy with the results. Next. Okay, so this is just, Marion and I, we founded a charity clinic. Nicole worked at the clinic. She's here today. We did a charity clinic from 1994 to 2005 in a very poor area of Illinois, Alexander County. So when the clinic ended in 2005, we sent the records to Doug Puller, who lived in Idaho. He was about the most honest person I ever met. And so what we did was we did a retrospective study. So we did retrospective study, just kind of seeing what at this charity clinic with just dextrose prolotherapy, no PRP, no stem cells, just dextrose prolotherapy. How were the long-term results? Did prolotherapy long-term keep the person out of pain? So if you go to our website, you'll see we have the results of the ankle, the knee, the back. Like the knee, for instance, that's 119 knees, which each knee represents 4 patient treatments. So just that paper alone is over 500 prolotherapy sessions. So you can see that the pain relieving results of prolotherapy were dramatic. Next. Then I called cure 90% or greater pain relief. 90% or greater pain relief. So in the end, we had data on 704 patients. The average number of visits was 4. So you got to realize this data is with 3,000 sessions of prolotherapy, which is a lot of prolotherapy. Then these patients were not educated much on exercise. We didn't go through diet in detail because the clinic was run over 2 days, and often we would see between 300 and 500 patients. So if you realize in 2 days we're seeing 150 to 250 patients a day. So this was just prolotherapy, and in the end the cure rate was 72%, and they all had basically chronic pain. So these were like end stage cases. Next. Yeah, the average, if you look at that data, that was patients were called like 1 to 2 years after their last prolotherapy session. But you always have to remember, I've done prolotherapy for 27 years. And then I took over the practice of Dr. Hemwall, who had been doing it for 40 years. So when I say that you get long-term pain results, like pretty much every week, I'm going to see one of my old patients that I saw 20 years ago, 15 years ago, and they haven't had any back pain, ankle pain. I told you, even in my case with my ankles, I haven't had an ankle problem in over 20 years. So the reason why you can't do like studies over 10 years now is because people move. When I inherited Dr. Hemwall's charts, he had over charts of over 8,000 patients. We called 100 of them because I wanted to see to get long-term results with his treatment. We only got a hold of 2 people, so that's why we stopped that data. Dr. Hackett, who did research in the 1950s, well, back then people stayed in their houses. So Dr. Hackett, for instance, in low back pain, he had results of people anywhere from 10 to 15 years. I think the average was 12 years, and the cure rate was the cure rate was like 80%. No, let's see, my cure rate was 72%. Hemwall's was 75. Yeah, 82%. So Dr. Hackett's cure rate was 82%. Hemwall in the 70s did a study on 2009 patients that he had an orthopedic surgery resident do, and it was like 2005 patients. The cure rate was 75%, and with our Thebes data, which is 704 patients, our cure rate was 72%. So you can see, if you did all that data, that would be over 5,000 patients. The cure rate for chronic pain was going to be in the 70s, like 78% if you took all that. This is a summary of some of our papers. Glenoid labral tear, the cure rate was 69%. Pain went from 7.6 to 0.6. Hip labral tears, 21 patients, 12 months follow-up, 54% cure rate. Pain went from 7.5 to 1.3. Meniscus tears, remarkable results too. Of the 28 patients, only 1 needed surgery. 27 did need surgery after prolotherapy. Cervical instability, again, remarkable results. So definitely somebody with chronic pain from osteoarthritis should consider getting an evaluation for prolotherapy next. Then these are some more commonly asked questions. His range of motion is becoming limited. The person that went to an orthopedic surgeon, the orthopedic surgeon wanted the person to get a knee replacement, and they've already had 2 surgeries. Can they get prolotherapy? We would do an analysis, an ultrasound, and see if there's ligament laxity. So if there was ligament laxity, then the ligament laxity is causing the pain, because remember, arthritic pain is normally from the ligaments. Just get prolotherapy. Once the ligament's tight, then the pain goes away next. Stem cell therapy. The person's in their 70s and they're wondering about amniotic cells or, amniotic cells, and if younger cells would help. Again, like I said before, it's the forces on the cells that are causing the person's own stem cells not to work so good. So amniotic cells aren't going to work in most people. I didn't say all the people. They're not going to work if you have joint instability, because those cells are going to get injected there and they're just going to get crushed to death like the stem cells and the cartilage cells that are already in there. So you have to make sure that if you go that route, just make sure the doctor treats the ligaments. But again, I would suggest that make sure that you get prolotherapy to the ligaments if you're going to consider getting a stem cell procedure. Next. Platelet-rich plasma. Platelet-rich plasma definitely attracts stem cells. Platelets contain all the growth factors, basically almost all the growth factors that are needed for healing. When you sprain your ankle, there's a lot of bleeding. Platelets rush to the area to stop the bleeding. That's why there's platelets there to begin with. When the platelets stop the bleeding, they release the growth factors. So when you have an injury, the platelets have to change their shape. They actually go over the wound. When they change their shape, they release the growth factors. Growth factors such as fibroblastic growth factor that causes fibroblasts to grow, vascular growth factor that causes new blood vessels to form, and also platelets attract the stem cells. So if somebody has a ligament tear and then a tendon tear, so we've healed up to a 70% patellar quadriceps tendon tear. So we have at Caring Medical up to a 70% tear, and the orthopedic surgeon said to the patient, it's like spaghetti in there, you need surgery. And the person said, nope, I'm going to Caring Medical, and that person now is running, the person's playing golf, the person's working full time, and they're doing great. So labral tears, tendon tears, ligament tears, consider getting platelet-rich plasma. Next. So if somebody has a ligament injury, there's only two choices. Either the joint instability is going to continue, and the person is going to end up with joint gangrene or diffuse osteoarthritis, whole joint destruction, or a person is going to get prolotherapy to the ligaments, causing tightening and strengthening. They'll get resolution of the joint instability. The joint will get stable. Forces will get back to normal, and the joint will function normally, so the person can put incredible amounts of force on it by running, skiing, cycling, weightlifting, and they'll be fine. Next. This just shows you, like, if you actually research the amount of pain relief, like if you go on Google and you type in PRP osteoarthritis or some of the other clinics, even some of the well-known stem cell clinics, you'll see that the amount of pain relief on a scale of 0 to 10 is on the order of 1 to 2. Where our studies, the data in Thebes, the Thebes data, the pain relief was 4.2. And when we did that study, when we did bone marrow inside the joint and prolotherapy to the ligaments, the pain relief was 5.8. So even with lipoaspirate and bone marrow, when people just get that injected into the joint, even though there's millions of stem cells, the amount of pain relief most studies show is only 1 to 2. Where when you treat the ligaments, the pain relief, like I told you, it's just hypertonic or concentrated dextrose, D-glucose, the normal sugar in the body. Our charitable work that we did, those patients got 2 to 3 times the amount of pain relief as the people that got the high-tech stem cell therapy. So anybody with pain from osteoarthritis, realize the pain is coming from the ligaments, and the ligaments need to be repaired with prolotherapy. Next. So I would really encourage you to get cured of your pain. Don't settle just for pain management. In the year 2019, there's definitely treatments out there that can cure arthritic pain, and that cure is prolotherapy. Next. We'd love to send you the book, Curing Chronic Pain with Prolotherapy, so please go to our website, caringmedical.com. Email me at drhauser, drhauser, at caringmedical.com. We'd be happy to send you the file of that book, and please read the chapter on osteoarthritis. Next. So thank you so much for joining us. I look forward to answering more of your questions at drhauser at caringmedical.com.